But thank you, everybody, for coming. We are here to talk a little bit more about glaucoma, help people understand what glaucoma is and what we are trying to do to address it. My name is Dan Dignazuski, and I'm the Executive Director for the National Alliance for Eye and Vision Research and the Alliance for Eye and Vision Research. And we are the hosts of today's briefing, and we are a 501c3 nonprofit organization that aims to educate about the value and impact of vision research through our research savings site Restoring Vision initiative. Our mission is to ensure the best eye and vision care by educating about and raising awareness about the value of vision and the value of vision research specifically, especially that funded by federal support that helps support that foundational research to try to treat patients and improve care. I want to thank our sponsors, the Association for Research in Vision and Ophthalmology, Research to Prevent Blindness, AbbVie, Johnson & Johnson Vision, and TEA. We really appreciate the support that helps provide these briefings to members of Congress and policymakers to be able to help elevate different conditions throughout the year as part of that research saving site Restoring Vision initiative that we have. So really quickly, a little bit about glaucoma. Glaucoma causes a tunneling of vision. So normal vision, you can see, is pretty expansive, but as you start to experience glaucoma, you start to see a narrowing and a tunneling of vision that can lead to irreversible blindness. There are over 3 million Americans that are living with glaucoma in the United States, and many of them may not know that they have it because the progression of the disease can be very slow, so early detection is absolutely essential. The prevalence of glaucoma is expected to double within the next 25 years. So by 2050, with an aging population that we have, with over 10,000 Americans turning 65 every day, we are expecting glaucoma and other age-related eye diseases to increase substantially over the next 25 years. Glaucoma is also known as the silent thief of sight. Over 120,000 Americans are blind to glaucoma, and the risk for glaucoma does increase substantially as you age, although you can be diagnosed with glaucoma at any point with congenital glaucoma, juvenile glaucoma, and secondary glaucoma. Glaucoma, it does cost the United States about $6.1 billion annually through direct and indirect costs related to healthcare, lost productivity. African Americans and Hispanics are 4 to 5 times at higher risk for glaucoma, and currently the current treatments, which we'll hear a little bit about, are able to slow progression of glaucoma, but not necessarily fully stop or cure the disease, and it is not resulting in substantial restorative vision or reversing of vision loss. So those are some of the challenges we have to try to address glaucoma as a disease and as a condition. The Alliance for Eye and Vision Research educates policymakers about the importance of federally funded research and the need for federally funded research at the National Eye Institute within NIH. It's one of the main areas for research funding for vision is the National Eye Institute. It's the only institute that funds research dedicated to a single organ, and it has resulted in sight-saving discoveries over the last several decades. The National Eye Institute and vision research funded by the National Eye Institute plays a substantial role in the early treatments and discovery of eye disease and opportunities for treating vision loss, including glaucoma, and is really the primary source of funding for most academic research institutes and academic researchers that are focused on vision research. So with that, I'm going to turn it over to our primary speakers here today. I'm going to start with our patient perspective. Hillary Golden, who is from New Jersey and is coming up, no, not New Jersey, Louisiana. That's right. Hillary Golden's coming, and she's going to share a little bit more information about her experience with glaucoma and understanding what it's like to live with glaucoma and why we need to address it. So, Hillary.
Thanks, Tim. Thank you, guys. Appreciate you being here today. It might be better if it's a brain tumor. That's what I thought as I laid down on the MRI platform. 2 radiology techs were attempting to put a cage over my face to keep my head still. I freaked out and started hyperventilating. I had had MRIs before, but this head cage was too much. After a couple minutes, I calmed down and sat up and said, I think if we cover my eyes and I can't see this cage at all, I'll be able to do it. They questioned my strategy, but it worked, and we got the MRI that we needed. A brain tumor that could possibly be removed or treated seemed like something that might be better than not getting back the almost 40% of sight that I'd lost at my diagnosis and the thought of potentially losing more. The results came back, and it wasn't a brain tumor, it was glaucoma. Currently, the sight I've lost can't be restored, but there are studies underway. And Dr. Johnson, who's going to speak to you in a few minutes, is undergoing a lot of those studies himself. One day we might be able to do it. For now, I can see okay because the pieces of my sight that I have left fit together well enough. Today I'm going to piece together my story for you. In July of 2020, I was working out multiple times a day, journaling, trying to figure out a way to have a normal schedule until the world in general got back to normal. It was during this time that I had a sty that wouldn't go away. I made an appointment with an optometrist, and we did a full eye exam. The tech asked me to read letters on the wall. And after I did that, she said, "Your vision is 20/20. Winning," right? She dilated my eyes, and the optometrist came in the room. The first thing she did was look inside, and she said, "I don't like the look of your nerve." The look of my nerve? Did you hear about that test that I just did? That letter test? I got a great score on that. And I mostly hear about this sty, so that's my main concern today. She said, "Well, my main concern is your optic nerve." My optic nerve? I knew nothing about optic nerves at the time. She had me cover one eye and asked me how many fingers she was holding up. "I can't see your hand." "Am I supposed to be able to see your hand?" Her voice softened. She moved her hand across my face and said, "Just tell me when you can see my fingers." I said, "Okay. I see there's 2 fingers up." She said, "I think you have glaucoma." "Glaucoma? Don't you have to be like 70 to have glaucoma?" "I need you to come back. We're going to do some more tests." "Okay. I need you to promise me that you'll come back." My head started spinning, and I told myself that she was overreacting. "Promise me." "Oh, okay, I'll come back." A couple days later, I come back, we do some more tests. She says, "I need you to see a glaucoma specialist. I'm going to make a phone call and get you in as soon as possible." A couple days later, I go to the office of the glaucoma specialist, where she confirms the glaucoma diagnosis. She gives me a bottle of eye drops to use and says, "I want you to use these," and she schedules an MRI to make sure that there's no neurological involvement. I asked her, "Can I just get some antibiotics and be done with this?" And she said, "That's not how this works." My eye pressure was 13 and 14 at diagnosis. Just for reference, normal eye pressure is 21 or below. And normally, glaucoma is a disease of high eye pressure, which causes damage to the optic nerve. I had been to 4 different ophthalmologists in the 6 years prior to my diagnosis. None of them found it. Most of the time, glaucoma is a slow progressing disease. Maybe my damage happened all at once. Maybe my eyes looked normal when I went to see the doctor. Maybe because my pressures were so low, it didn't raise a red flag for them to look further. Maybe. I'll never know. But what I do know for sure is glaucoma is not only the silent thief of sight, it is also a very, very sneaky disease, because as you lose pieces of sight, your brain is filling in the data. So you don't realize that you're losing sight, and there's virtually no symptoms until you have severe disease. there are visual fields that you take, and when you're losing sight, your sight turns to shades of gray, then black, and then another missing piece of sight. There are 3 challenges with glaucoma that I want to talk to you guys about today. The first challenge is drops. So I mentioned earlier about these drops, right? So these drops lower pressure. So even with low pressure like I have a strange kind of glaucoma, of course, but even with normal tension glaucoma that I have, you still want to get the eye pressure lower. The problem is these drops have something in them called BAK. And they're in there for a purpose. The purpose of that is to keep bacteria from growing inside those bottles of the eye drops, which is great intention. But over time, that BAK is kind of like bleach. Over time, it causes damage to the surface of the eye. The best way to explain this is if you think of something really benign, like you're putting on a moisturizer on your arms. Okay, so your skin's kind of dry, you put on a moisturizer. On your left arm, you put just straight moisturizer. On your right arm, you've got moisturizer that's mixed with bleach. So it's half moisturizer, half bleach, because a lot of these drops have more preservative in them than they do have medicine. So on your right arm, you're putting your moisturizer with a bleach. Over time, what do you think is going to happen to your arms? I mean, I haven't done this study myself, but Dr. Johnson might know better than me. But what I'll tell you that I think would happen is potentially your right arm's going to be really irritated. You might even get, break the skin and get an infection potentially. So over time, think about the delicate surface of the eye. This is what happens to the eye. Over time, it erodes. People that have been on glaucoma medicine for years and years and years eventually need corneal transplants, some of the patients. So as you're helping one problem, you're causing another. The second challenge that I'm going to talk to you about is the number of glaucoma specialists. There's not enough glaucoma specialists out there. And when you go see the glaucoma specialist every 3 to 4 months, then you get a limited amount of time. My personal glaucoma specialist sees from 75 to 100 patients a day. Think about if you were going to a doctor that was seeing, even on the low end, of 75 patients a day. I get about 4 minutes with my glaucoma specialist. So that's every 3 months, and she's going to look in my eye, she's going to make sure there's nothing else going on, she's going to look at my tests, and then I've got to ask her questions, and that's all got to fit within that 4-minute time frame. Do you think I get to ask all the questions that I have? I don't. This is a chronic disease, so as you learn more, you have more questions. Good thing for me, I have other doctors to reach out to, but most of those patients don't. Also, these doctors are limited in what they can offer their patients because of Medicare and insurance. So only certain procedures are approved, certain surgeries. So a doctor might think one surgery is best for their patient, but they're not able to do that surgery because it's not approved. So they have to go to their second, third, or fourth choice to perform that surgery instead because they can't do their first priority surgery that they think might be the best for that patient. So that can be very frustrating to doctors. The third thing I want to talk to you about is waiting. So as a glaucoma patient, I never know if or when I'm going to lose more sight. I always hope that I don't, but you never know if today's the day. So when you're crossing the street, not only do I look both ways once, but I look both ways twice or 3 times to make sure, like, what if today is the day that I lost another piece of sight and I don't see this car coming? Once I realized what these challenges were and how they impacted me, I realized that I had to take control of the disease for myself. To my glaucoma specialist, I am one of 1,000 patients, thousands of patients that she has. But to me, I'm one of one. I had to get out of the car, stop the car that day that I realized this, get out of the passenger seat, get in the driver's seat, and take control myself. Because I had to become my own hero and take care of this for myself. I'm the only one that can save my sight, ultimately. Now I coach other patients and help them become their own hero as well. So how do all the pieces of my story and my sight fit together? And what is blindness anyway? Blindness is not black and white like I used to believe. It's varying degrees of sight. The way I explain it to people who haven't lost sight is it's like a puzzle. So say you're putting together a puzzle and you've got the pieces on the table and it's all together, but you're missing some pieces, right? It's very frustrating. So you look on the ground, under the table, under the sofa, maybe the dog ate them, but you can't find those pieces. So you've got this picture with these blank spaces. That's what it's like when you lose sight. You lose these missing pieces. I can still see okay, even though I've lost 40% of my sight, because my brain fills in some of that data. But it's scary to think that I might lose more sight one day. This is where I found the secret of life. You didn't know you were going to come to this today and learn that, did you? So what I found to be the secret of life is to hold two competing beliefs at the same time. So on one hand, I understand the severity of my glaucoma and the absolute possibility that I might lose more sight. And on the other hand, I have complete and absolute faith that I won't. Holding these two beliefs at the same time gives me a sense of peace. And it's absolutely necessary for me to move forward. But I have no control over that. The only thing I have control over is my reaction and my focus. And when I focus on the 60% of sight that I have instead of the 40% that I've lost, it changes my focus. If you shift your focus, you change what you see, even if you can't see. So I'll ask you, where can you shift your focus today to see something different? And finally, I'll leave you with this. When you have the opportunity to make a difference in a patient's life and with healthcare in general, always, always, always start with the patient. Thank you.
So you've heard a little bit about Hillary's story, and one of the things that we are going to provide everybody an opportunity to do at the end of the briefing here is actually experience what living with glaucoma and seeing with glaucoma is like. We have a virtual reality simulator here that actually simulates what glaucoma is and what your vision may look like from mild to moderate to severe stages of glaucoma. So if you stick around and want to check that out, we encourage you to do so you can experience some of that. At this time, I'm going to invite our second speaker up, Dr. Tom Johnson from Wilmer Eye Institute, to share a little bit about what we're doing to try to address this disease through research and some of the progress that we're making. So, Dr. Johnson.
Thanks very much, Dan. So my name's Tom Johnson. I'm an associate professor of ophthalmology at Johns Hopkins, just up I-95 in Baltimore. I'm a glaucoma specialist and also a neuroscientist. So I spend part of my week in the clinic and in the operating room treating patients with glaucoma, and then I spend the rest of my time in the lab doing research to try to develop better diagnoses or better treatments for the disease. Now we're here in the Rayburn House office building at the U.S. Capitol, and so what I want to try to do with the next 20-30 minutes is give you guys in the audience the information that I think you need that's most relevant to you, which is understanding glaucoma and how it affects U.S. citizens and how the federal government can help reduce the morbidity of the disease. So I want to start with just some basic descriptions of the disease and some of the science behind what's going on in glaucoma and how it causes vision loss. So glaucoma is what we call an optic neuropathy. It's a disease of the optic nerve. You've heard that term used already today. But it's not the only disease of the optic nerve. There's actually lots and lots of different diseases that can all cause degeneration of the optic nerve. Glaucoma is special, though, because it's the most prevalent. There's over 100 million people in the world with glaucoma, and 10% of them are bilaterally blind from the disease. Glaucoma, as we've heard, is related to and caused by pressure building up inside the eyeball. The eyeball is like a water balloon, and the more water you try to stuff into that balloon, normally a water balloon would just get bigger and bigger, but the eye can't because it's got a rigid wall and it's stuck inside the bony eye socket. And so instead of getting bigger, the pressure just builds up inside. And when the pressure builds up, it pushes on the optic nerve in the back of the eyeball and causes damage to it. The optic nerve is the main nerve that connects the eyeball to the brain. And as that gets damaged, it causes vision loss. Now, this is often what people use to describe glaucoma, that you have tunnel vision or you have this area of blackness in your periphery, but you have good vision in the center. And that's not really true. As Hillary has told us, one of the problems is that your brain doesn't expect to have areas of missing vision or blackness in the periphery. And so you don't interpret the world with areas of blackness. Your mind fills them in with what it thinks is supposed to be there. And while it seems like that would be great because you fill in missing vision, maybe you're more functional, you can adapt better, it's actually a problem. And this shows why. If you look at the top left, you have this picture as someone might see a little town in England with some cars parked next to some buildings. If you lose your vision and your brain tries to fill it in but doesn't really know what's there, you might not see that there's a door in one of those buildings or a car somewhere else. And that's why glaucoma is such a sneaky disease, because you don't wake up one day and have this big black spot that you say, oh my gosh, what's happened? That tends to happen in macular degeneration, and that's why it's picked up very quickly when it affects patients. But in glaucoma, your mind fills it in. You gradually have these areas where you're not really seeing the world as it is, but you don't recognize that right away. Glaucoma is also one of the few eye diseases that, if not adequately treated, can cause complete and total blindness, where you can put somebody in a room and shine a spotlight in their face and they would not know if the lights are on or off. They have no light perception. Most other diseases won't do that. Macular degeneration, you might be unable to read or recognize faces, but you'll still have peripheral vision to navigate the world. Glaucoma impacts people at all stages of the disease. I think patients with glaucoma, in my experience, are often worried about becoming blind, and that, of course, is a very scary thing. But even people with mild and moderate disease have vision issues that affect them in ways that prevent them from functioning well in everyday life. Even though you may have reasonable central vision where you can read that Snellen chart, the big E and the letters below it in an eye doctor's office, that's an idealized setting where you have a white background and bright, sharply defined black letters and lots of light showing. People with mild glaucoma have reduced contrast sensitivity, which means they have trouble seeing things unless lights are really bright. One of the earliest complaints I have of my glaucoma patients is they say either when they're in a restaurant and it's dimly lit, they can't read the menu, or when they're driving at night, they can't see any of the street signs. And so well before people go blind from glaucoma, they have to adapt their whole lives. And many of my patients stop driving at night relatively early on, even when they have 20/20 vision, because they're just not functioning at the level they need to be. So there's a lot of things that affect patients with glaucoma: driving, restricting activity. It's also been shown through research at Johns Hopkins that people with mild and moderate glaucoma, even though they can see well, that area of missing vision affects their mobility, and they're at greater risk for falls and fall-related injuries because of mild glaucoma. Now, how does the doctor know a patient has glaucoma? Well, as Hillary just told us, they look in the back of the eye and they take a look at the optic nerve. So what you're looking at here is a picture of the optic nerve in the back of somebody's eye. The nerve is sort of like a cylinder coming off of the brain and inserting into the back of the eyeball. And if you look at a cylinder on end, it looks like a circle or an oval. And so that's exactly what you're seeing on the left. And that oval has sort of a pinkish or orangish appearance, and it's got a tiny little hole in the middle called the cup. So I often talk about the optic nerve head as a donut, and what you want is a donut with a small hole in the middle and lots of dough on the outside. As people get glaucoma and the optic nerve gets damaged, the dough of the donut starts to die away, and so the hole gets bigger and bigger and bigger, and that's what you're looking at on the right. That's an optic nerve where there's just a tiny little sliver of donut left. Most of that thing is the hole, and what that is representing is the nerve tissue having died away, probably from years of living with this disease. As we've heard already, glaucoma is treatable by lowering the eye pressure, but it doesn't always work as well as we would like. Some patients have eye pressure that continues to be high despite our best efforts doing eye drops and lasers and surgery. And the other thing is, because this is such a sneaky, insidious disease, a lot of patients show up to the doctor and are diagnosed for the first time having already lost half their vision. And we have no way right now of getting that back. So, to go into slightly more detail, this is a cross-section of a human skull. You see the eyeball there. That yellow cylinder, that wire coming off the back, is the optic nerve. The optic nerve then goes into the brain, and it connects to very specific parts of the brain that are meant for supporting your perception of vision. And that's what we're showing on the right. The optic nerve is itself not one big solid structure. It's actually made up of fibers from retinal nerve cells called retinal ganglion cells, or RGCs. And on the left here, you're seeing a mouse retina where just a fraction of the retinal ganglion cells have been labeled with a fluorescent protein. So you can see they dot the retina all over the place on the inner wall of the eye, and they send a fiber straight to the middle like spokes on the wheel. Those fibers are all the axons of retinal ganglion cells that are entering the optic nerve. These retinal ganglion cells receive information about light entering your eye from the other types of cells in the retina. So on the back here, you have the rods and cones. These are the cells in the retina that detect light and turn it into an electrical signal that your brain can interpret. They pass that information on to bipolar cells, and the bipolar cells pass that information on to the retinal ganglion cells, which are the gray cells up front here. Those cells then send an axon through the retina into the optic nerve and into the brain. So what you're looking at here is a cross-section of the optic nerve head, and normally you have all these fibers of these healthy retinal ganglion cells coming out the back of the eye and entering the nerve. So these fibers up here are essentially the orange part of the donut that I was talking about. And as those die, the donut gets thinner. The rim here is very, very thin, and you end up with a much bigger cup or hole in the middle. That's what defines glaucoma. So glaucoma causes vision loss by killing retinal ganglion cells, those nerve cells of the optic nerve, and in doing so, it disconnects the eye from the brain. So how do RGCs connect the eye to the brain in the first place? Well, retinal ganglion cells are nerve cells like brain cells. They have three main parts: a cell body, which is like the headquarters of the cell. They have these long finger-like projections, which are called dendrites, and they use those to listen to the rods and cones in the retina and receive information about light. And then they have a long fiber, an axon, and that's what goes to the brain to communicate that information about light to the brain centers. The dendrites are like the part of the cell that's listening, and the axons are the parts of the cell that are talking. So the retinal ganglion cells are playing a role in vision that's sort of like a game of telephone. The child at the beginning will whisper a word in one child's ear, and then they'll hear that word, pass it on to the next child, and so on until the message gets to the brain. But I think in this day and age, a better analogy is when you're setting up your cable box at home. You have a cable outlet, you got to plug it in with a wire to your cable box, and then that cable box plugs with an HDMI cable into your TV. So in this analogy, your TV is your brain. The cable outlet are those rods and cones that are getting the raw signal about light entering the eye. The cable box are your retinal ganglion cells, and your optic nerve is the HDMI cable that connects the cable box to your brain. So the coax cable that connects the cable outlet to the back of your box are how your box listens to the signal about your television coming in. And the HDMI cable is how it sends that information to your TV. So in the reverse analogy, the brain is your television, the retina is the cable outlet, the cable box are the RGCs, and that HDMI cable is the optic nerve connecting the retina to the brain. So the optic nerve, as I was saying, is not just one big tube. It's actually a fiber optic cable. Inside it, it has a million tiny little nerve fibers of retinal ganglion cells that are each sending a unique message about something in your visual field from the eye to the brain. So the optic nerve is like a fiber optic cable. How do retinal ganglion cells receive information and communicate it? Well, it's all about connections between nerve cells. Just like in your brain, we're talking about how cells are talking to each other, and that all occurs at a communication station between nerve cells, which is called a synapse. At the synapse, there's these small areas where two neurons are very close to each other, and they send messages to each other by releasing neurotransmitters, and those are the messengers of a synapse. So for retinal ganglion cells and the optic nerve, there's two places that synapses are important. One is in the retina, where retinal ganglion cells are receiving information from the rods and cones, and the other one is in the brain, where they're sending those messages to the brain centers that support vision. And in both places, they're doing this through synapses. Now, what is happening at synapses, those neurotransmitters are causing the cell on the receiving side of the synapse to change its electrical state. This is an example. If you put an electrode in a nerve cell, you'd actually see that it changes its electricity state very quickly in what's called an action potential. So you can measure this, and if you record from a cell a single neuron over a long period of time, you see a whole bunch of action potentials in various states of on and off. So this is an example of what a neuron might look like if it's sending a message. It has a bunch of little action potentials, then it goes quiet, then a bunch more action potentials, then it goes quiet. And it does this in a pattern that your brain decodes into a picture of the world around you. Now, this is sort of some heavy neuroscience concept, but the way I would think about this is that your eye and your brain are using sort of a Morse code signal to send messages about the light that's coming into your eye. So just like the Tuskegee Airmen in World War II sending messages, your nerve cells are sending pulses of ons and off, dots and dashes, to communicate messages between the cells. So that's a little bit about what glaucoma is, why the retinal ganglion cells and the optic nerve are critical to vision, how it works, and why you lose vision if glaucoma kills the retinal ganglion cells and the optic nerve. Now I want to talk about three keys that are what we as glaucoma doctors think about right now for how to prevent vision loss in our patients. The first thing is routine eye exams. Hillary was talking about the fact that even she had seen eye doctors several times in the years leading up to her diagnosis, and it can be hard to detect. But a lot of Americans over the age of 45 don't see an eye doctor unless they have a problem or need updated glasses. Because glaucoma is such a sneaky disease, if you wait until you have symptoms and recognize a visual problem to see the doctor, you're going to have terrible disease. The United States Preventive Services Task Force recommends that people over the age of 45 see an eye doctor for a comprehensive exam once a year. And right now, those are our best, most cost-effective recommendations for glaucoma screening. As was alluded to, the prevalence of glaucoma is high, and it's going to get worse. Right now, it's on average about 2% of the population that's greater than 40 years old. If we take just Texas as an example, that means there's almost 250,000 people in Texas with glaucoma as of 2011. Now, as of 2050, as the population ages, people live longer. We have more people in the United States over the age of 40. The rate and the prevalence of glaucoma is going to double, and there will be over 800,000 people in Texas alone living with glaucoma in about 25 years. As a glaucoma doctor, most of my job is monitoring the disease and making sure that people are stable and not continuing to lose their vision. We do this in a couple of ways. We could take very sophisticated scans of the retina and the optic nerve. One of those is shown here, called optical coherence tomography, or an OCT. And this can show us a picture of the retinal health with a resolution and level of detail that's almost as good as histology, if you had a piece of tissue and you looked at it under the microscope. The other thing we do is measure people's peripheral vision using very sensitive tests. This is called perimetry, and this is a patient that is inside of a perimeter. Her head is in front of this bowl, and she's looking at a target spot. And the machine will show a light somewhere in her peripheral vision, and if she sees it, she'll click a button, and if she doesn't, she won't. So the machine will map out where she's able to see all the lights, and then it will make the lights dimmer and dimmer and dimmer and dimmer until she can't see them anymore. And by comparing to a known reference data set that tells the computer what someone her age should be able to see in every spot in her peripheral vision, it can create maps like this one, where it tells us that on the nose side of the left eye, she has this big arc of area where the lights have to be much, much, much brighter than normal in order for her to see them. And that's a glaucomatous visual field defect. The last thing that we do to prevent glaucoma from getting worse is to control the eye pressure, to reduce the intraocular pressure. Now, some of my ophthalmology colleagues like to make fun of us glaucoma specialists and call us eye plumbers, because most of our job is just worrying about what's going on with the fluid state of the eyeball. So the eyeball, again, is like a water balloon, but it's not static. There's actually tissue inside that water balloon that's constantly creating more water to keep the water balloon filled up. And then there's a drain that is draining fluid out of the eyeball at approximately the same rate. And when those two things are balanced, people have normal eye pressure. But if the drain gets clogged up, it's like an overflowing sink. But instead of the fluid overflowing, there's nowhere to go in the eye, so it just builds up and raises the pressure and causes glaucoma. So at this point in time, the only thing we can do to treat patients with glaucoma is lower the eye pressure, and we do that by prescribing eye drops, using lasers, or by doing surgery to install new drainage systems in the eye to release pressure like a safety release valve. The last thing I want to leave you with here is a statement that it's true that the United States leads the world in biomedical research and in glaucoma research specifically. And right now we're positioned to change the clinical paradigm of what patients with glaucoma experience, being able to save vision for countless patients and potentially actually cure blindness and restore vision that's been lost. And I just want to give you some examples of the payoffs that have come from investment by the United States federal government into glaucoma research. Because these examples not only show how we're going to be able to take better care of patients and prevent vision loss, but these also represent new United States biotech companies that are creating jobs and contributing to the GDP of our country. So one area of glaucoma research for a long time has been understanding eye pressure. And right now, the standard of care is to check a patient's pressure whenever they go in to see the doctor, which, as we heard, might only be every 3 to 4 months. Sometimes it's every 6 to 12 months. But eye pressure, like blood pressure and like blood sugar, is not a static number like your height that doesn't change. It's a number that's constantly going up and down 24 hours a day, 7 days a week. And so by taking eye pressure just once every few months, we're not really understanding the stress that an optic nerve is under, and we're missing a lot of patients that have unsafe high eye pressures but just happen to have a fine eye pressure that one time they were in clinic with the doctor. So there are now companies that are developing implantable and wearable intraocular pressure sensors. Just like how patients with diabetes can slap a glucose monitor on their arm and then look at their phone and know what their blood sugar is doing every second of the day, these are devices that might be implanted into the eye and tell someone through their iPhone exactly what the eye pressure is doing 24 hours a day, 7 days a week. Artificial intelligence is obviously a huge topic pretty much in all walks of life, and there's no exception in glaucoma. There's active research going on to use AI to better diagnose, better screen patients for glaucoma. Once you know that a patient has glaucoma, to try to predict, are they at risk for getting worse quickly, or are they likely to have a very slow progression of their disease and don't need as much aggressive treatment. So continued investment into AI is, just like all aspects of medicine, going to really increase our capabilities in the near future. Neuroprotection is a key area of glaucoma research. As I told you before, the only thing that we can do right now to prevent glaucoma from getting worse is to lower the eye pressure. But what if we could make the optic nerve more resilient, make it stronger so that it would be perfectly happy living in the brain with a higher eye pressure? This would give us a second way to treat glaucoma through an independent mechanism of action and be able to save the vision of hundreds of thousands of people that are continuing to get worse even though eye pressure is as low as we can make it. So the National Eye Institute has been supporting research in neuroprotection for about 15 years, and there's now, I put just 4 companies up here that I know about that have publicly communicated the phase 1 and phase 2 human clinical trials that they have ongoing right now of potential new glaucoma drugs, and there are other companies with similar drugs in the pipeline. So again, I think due to the investment in research, we'll have new drugs to better treat people, and we will have new biotech companies that are contributing to our economy. The last thing that I'll leave you with is what my laboratory studies primarily, and that's the prospect of actually curing blindness by restoring vision that's been lost. Now, in order to do that, since the retinal ganglion cells that a patient with glaucoma was born with have died, we need to actually restore their retinal ganglion cells, and we think we can do that by transplanting stem cell-derived neurons into the eye. It's a complex task because there are several different challenges that need to be overcome, because again, that nerve cell that you transplant into the eye has to create a fiber that goes all the way to the correct location in the brain and communicates information about vision entering the eye if you want it to restore vision. But we've made a lot of headway. This is a video from my laboratory where we've transplanted red-labeled human stem cell-derived retinal ganglion cells into an animal model of glaucoma, and then used a special kind of microscope that can take 3-dimensional pictures to look at what that cell is doing 2 months after it's been transplanted. We've highlighted it in white so you can see here, and what I want to point out is that it's grown dendrites, those listening arms of the cell, into the exact layer of the retina that it needs to in order to receive information about light that's coming from rods and cones. Not only that, but we've shown now that the cell is receiving that communication and responding with action potentials, with Morse code, telling us that it's recognizing the pictures that we're showing the animal. This is a movie where we have engineered our retinal ganglion cell transplants to have a special protein that glows brightly whenever the cell is firing action potentials, whenever it's communicating dots and dashes of Morse code. And in this video, every 10 seconds, you see a bunch of those neurons become very bright, and then they go dim again. And that's because every 10 seconds, we're showing a picture to the rods and cones of that retina that we transplanted the cells into. So this is how we know not only are those cells surviving, but they're actually hooking up into the circuitry of the retina in a way that they're receiving information about light entering the eye. We've also been thinking very translationally to how we might deliver this to humans. We have done transplants in human post-mortem retinal tissue. So when patients are organ donors, but for whatever reason their eyes are not healthy enough to use for a corneal transplant or something that would benefit a human patient, the eyes are donated to science. And we've taken retinas and mimicked a transplantation of a human retinal ganglion cell into the eyes of human tissue and shown that we can get good engraftment just like we can in animal models. And we're now developing surgical techniques to actually do this in human patients. This is a video where one of our retinal surgeons at the Wilmer Eye Institute, Jim Handa, is peeling the internal limiting membrane off the surface of the retina of a human patient. You're looking through the microscope, and the instruments that he's using are being put through the walls of the eye. So it's almost like laparoscopic surgery for the eyeball. And he's peeling this membrane off the surface of the eye because it's a good treatment for a different disease we're not talking about today called macular hole. But our research has shown that if you remove the internal limiting membrane, that enables human stem cell-derived retinoganglion cells to integrate into a host retina. And so we're now doing sophisticated surgeries like this in preparation for doing this in human clinical trials. And this is an example of one such surgery that was done in a large eye where we see good survival of transplanted RGCs at 2 months after surgery, and they're sending their fibers, their axons, right to the optic nerve head on the way to entering the brain. This is another example of those human RGCs in a large eye. This time you see that their dendrites, the listening arms of their cells, are within the layers of the retina where they need to be to receive information about light entering the eye. So as far as vision restoration for glaucoma, we still have a long way to go. We still need to figure out how to get retinal ganglion cell fibers connected to the brain. And they can't just go anywhere in the brain. You know, the brain has very specific small areas that are responsible for all sorts of different functions. So we have to get them to go specifically to the parts of the brain that are subserving vision. We need to get them synapsed, get those communication stations set up, and make sure that connectivity is organized. But I think our work right now shows that this is no longer science fiction. It's just a matter of time before we work out the science to make this possible. A couple take-home points about glaucoma for the audience here. As we've heard, glaucoma is a serious neurodegenerative disease. It causes irreversible blindness, and it's one of the few diseases that can cause complete and total blindness. The personal healthcare system and socioeconomic tolls of glaucoma are enormous. The loss of productivity for patients that can't work because of glaucoma, the cost of visits to the doctor, eye drops, surgeries, lasers, it's all a huge burden, and something that if we can reduce that would be really good for this country. Glaucoma is insidious, it's painless, it causes vision very slowly, and it's hard to recognize, but early diagnosis saves lives. And so access to screening appointments and care for patients to detect this disease early and start treatment can really prevent morbidity down the road. The government's investment into glaucoma diagnosis and therapeutics have already paid off and translated into vision saved and economic productivity. And continued investment will not only continue this trend, but I think lead to really revolutionary treatments for the disease. It's my opinion that glaucoma science is at an inflection point now, where for the last 30 years, we've iteratively created better treatments to lower the pressure, but we're now at a point where we might be able to create completely novel treatments that prevent glaucoma from getting worse once it's diagnosed and actually restore vision for people that have lost it. And if we can achieve that, it would revolutionize medicine and really be a huge boon for citizens of the United States. So with that, I just want to thank everyone for your attention. I want to thank the people in my lab that have done a lot of the research that I've been speaking about. And I want to thank the funding that we've received from the National Eye Institute, from the United States Department of Defense, and from the ARPA-H program. Thanks.
Thank you, Dr. Johnson. I think what you've heard today is both from the patient perspective, the importance of early screening, early detection, the impact that it can have on people. You've also heard about what glaucoma is and a little bit about some of the great work that's being done to try to address this. So I want to leave you with a little bit more information. You all work with policymakers every day here up on the Hill, so a couple of things that you can do here today in your offices. First and foremost, support that dedicated National Eye Institute within NIH. There have been consolidation and restructuring proposals that have been floating around, and we want to make sure that the National Eye Institute remains a dedicated institute, that vision is prioritized at the national level, and that we continue to stabilize and increase that investment at the National Eye Institute to support vision research in conditions like glaucoma. I also want to encourage you to support the CDC's Vision Health Initiative and their glaucoma program. The CDC's Vision Health program and the glaucoma program help track and help us understand the scope of disease and different vision conditions across the country, glaucoma being one of those main focus areas. I also want to encourage you, and one of the things that we are working on is working with the FDA, Medicare, and private payers to identify opportunities to ensure that patients and physicians have access to all of the treatments that are available to them and make sure that we make those affordable and accessible to patients. We don't want to limit the care continuum. We want to make sure that patients have access to new and novel treatments and treatments that can improve their care. We also encourage you to become a member of the Bipartisan Vision Caucus. The Vision Caucus is chaired by Congressman Gus Bilirakis from Florida and Congressman Vassie from Texas. That caucus is a great caucus to be able to understand and keep track of some of the issues that are impacting not only vision research, but sort of vision care and access to treatment for patients. And the last piece that I'll leave you with is you heard about the importance of detection. This early detection bill is primarily focused on myopia and child health conditions with vision, but the Early Detection of Vision Impairments for Children Act, or the EDVI Act, was introduced in the 118th Congress, and we expect it will be reintroduced soon in the 119th Congress with bipartisan support. That bill helps with that early diagnosis and understanding of disease in children, and potentially may enhance some of those artificial intelligence efforts and early diagnosis efforts that we talked about a little bit today. So with that, I will stop there and thank our sponsors one more time for their support in helping bring today's briefing to you all. And I'll open it up for questions and see if anybody after questions wants to give a shot and try and see what vision loss looks like. Any questions? Any comments? No? All right. Well, thank you all very much for coming. Feel free to grab lunch if you haven't already. And for those of you that are interested in experiencing what glaucoma looks like, please come on up and we'll give you a chance to try that out.